I don't have glasses. And I'm just getting back on. Like, it's on my piece, but then like there's all the lessons. And there's the test from the introduction. No, it does. The introduction.
Oh, okay. And then everything done, done. You flipper. My shot, you have impressive. On Safari, the case studies on it. I tried to find out, I can't locate that. No, not yet.
I thought I put them on there. Let me see.
Oh, shoot, I just realized I didn't charge my camera. I was like, great, I'm gonna crack on stage.
Okay, Bree, the Dropbox has been made. Sorry? Yeah. No, just put them all in the one box and we'll go from there. You should be able to do multiple ones inside the one box.
They were fine. It's like nice out right now. They're all fine. Yeah. Wait, this was like nice. It was just that he really.
No, just some of, JC, David, or JC, some of the roads are flooded.
Oh.
Easily. And I was afraid that we're gonna, some of those roads have low spots in them. And they flood, easily. Have you seen that through again?
No.
No?
I know.
Is Emily too vain to come to class or?
She had something. She had
Oh.
something pop up that was a mistake.
that's not the ground.
Just ignore it.
Okay. Party started here. Okay, Becca, can you hear me all right?
Yep.
Excellent. All right. Okay, I just want to finish the growth factors that are used for people who are low on red blood cells or low on white blood cells or low on platelets. Then from there, we'll go to the GI drugs. So the GI handout that I gave you, well, I sent to you, if you have that, please make sure that's at the ready. So we talked last time about the erythropoietic growth factors, and we saw that there's epoetin alpha and the darbepoetin alpha. Darbepoetin alpha has a longer half-life and tends to be used for people with chronic kidney disease. So these are used for people with anemia due to chronic kidney disease. People have anemia because of chemotherapy. You can use it for that too. If you have somebody who's going to undergo elective surgery and it's clear they're going to lose a fair amount of blood in that surgery, you can use this before surgery to increase their red blood cell count. So when they lose erythrocytes during surgery, it's not that big a deal. It's also used by AIDS patients because some of the drugs used to treat HIV will affect the bone marrow and decrease your red cell count. So they're used for all those. Again, they're used either subcutaneously, they can also be given IV. They're not oral. These are peptides. If you give them orally, your GI tract will degrade them. So the caveats, of course, are going to be hypertension. Hypertension's a biggie. Excuse me, the blood pressure needs to be monitored pretty regularly. The other is that the patient is at increased risk for clots. So thrombotic events is also a potential issue. Deep vein thrombosis, of course, which is a thrombotic issue. So let's just say deep vein thrombosis. So know the signs of deep vein thrombosis, be able to watch. Remember, you're going to see DVT most usually in the leg, usually the lower leg. That's a place where it usually occurs. The leg is red. Above the clot, it's usually whitish, but it's red, it's tender, it's painful. And some people will get headaches and body aches. These can be severe in some people, but usually they're not bad. You give them, acetaminophen, something like that, that will usually deal with that. But in some people, their pain is substantial. So that is your erythropoiesis. So that's for people who are low on red cells. How are you going to know if the drug is working? RBC count goes up. So you're going to take just a regular complete blood count. So draw a little blood, do a CBC. That's going to essentially how you're going to take a look at discover this. Now you can get fluid retention. With this drug, and if you get fluid retention, that puts more stress on the heart, and that can lead to arrhythmias. You kind of get one with the other, albeit there are some people who will have cardiac arrhythmias. And remember, these drugs, when they were first put out, were pulled because people started having heart attacks on them. Well, it really wasn't clear how those drugs should be administered. Now that the dosage has been dropped and the dosage is better worked out, and the medical staff knows what to look for, the tendency for these drugs to cause cardiac arrhythmias and fluid retention is not nearly as great. But nevertheless, you should be listening to the patient's heart. And if you hear something funny, hook them up to an EKG. And if things really get out of hand, call cardiology. Know when you're over your head. And sometimes if you hear something you're not sure, call in your buddy and say, do you hear the same thing I hear? Nursing is something not done privately. It's something done as, it's collaborative. It's collaborative. All right. What about things for platelets? So the drug here is called opravelcin. This drug is not used a bunch. It does get used, but it's not used very often. Someone's low on platelets, usually they recover. Also, you can give them platelets. So this drug is not used a whole lot. It will increase the production of platelets. It'll decrease thrombocytopenia. That's essentially what it's used for, is for thrombocytopenia. So this drug can also cause fluid retention, and it can cause cardiac arrhythmias. The other thing it can do, and this is a little weird, why it does this is not clear, but it can cause eye pain. Eye pain. The eye may start to look bloodshot. The eye may start to get dry. The eye pain is, the vision may start to get blurred. It's just eye stuff, essentially. This is usually transient. Usually. 99 times out of 100 is transient. But if this persists, then call ophthalmology. You can use eye drops and things like that to wet the eye, to decrease inflammation. If the vision starts to really go south, you can give them some eye test, some fast eye tests. There are usually Snellen charts around. You can hold up a Snellen chart, ask them, can you read such and such, what and what? In fact, something you might want to do is give someone an eye test before they go on this medication, and then see how their vision changes. So that's probably the best advice with that one, is have something you can compare it to. Some people get allergic reactions to this medication. Not terribly common, but it's been reported. This drug is contraindicated in people with any sort of cancer of the bone marrow, anything like that. So lymphomas or chronic myelogenous syndrome, anything like that. It's there. Questions about either the erythropoietic or the thrombogenic medications? Again, that's also given with a needle, it's given parenterally. Drugs for white blood cells to increase white blood cell counts. These are used to decrease the risk of infection in people who have neutropenia. Neutropenia can result from, again, from chemotherapy. That's usually when it's used. So this would include, there's several different drugs in this group. They kind of all work the same. So there's filgrastim. Filgrastim is a granulocyte colony stimulating factor. So it's a granulocyte colony stimulating factor, filgrastim. A similar drug is called lenograstim. Lenograstim. That's also a granulocyte colony stimulating factor. A longer acting version of these drugs is pegylated. Pegylated, meaning it's been attached, polyethylene glycol has been attached to it. And it's called pegfilgrastim. Same thing, but this is long acting. And then another drug called sargramostin. Notice these drugs, they all end in stim because they stimulate the formation of these particular drugs. These are the G because they're granulocyte colony stimulating factors. So sargramostin is a granulocyte macrophage stimulating factor, GM-CSF. So these improve white cell production. The biggest problem with these drugs is bone pain. Bone pain. It can be severe. It can be bad. So have some analgesics at the ready. Acetaminophen is not going to hit this one. You're going to need to use opioids. It's that bad usually. When you do your CBCs, you can overshoot sometimes and you get leukocytosis. So this tells you essentially these need to be monitored. If your numbers go above 100,000 per cubic millimeter, if they get above that number, that's essentially your danger zone, essentially. You need to interrupt treatment or greatly decrease the dose if you get above that number. These proteins are they're made by genetically engineered organisms. The organism is E. coli. If your patient is allergic to E. coli proteins, you shouldn't use these, they'll react to them. They're clean, but they still have a few E. coli proteins in them, and some people will react to them. You can use them in people with cancer of the bone marrow, but you have to use them with great caution. Sargramostin, in addition to causing bone pain, typically also will cause diarrhea and nausea. And if someone gets diarrhea, of course, they're going to lose electrolytes and what have you. So you need to watch your electrolytes and some people get an infusion reaction with sargramostin. They get their heartbeat goes really fast and they flush. They get chills and fevers and stuff like that. The chills, have a nice warm blanket for them. The hospitals, they have blanket warmers. Make sure you have a nice warm blanket for them. You put it in. If they get chilled, you throw that blanket over them and you're going to be their best friend. How do you know it's working? There you go, Jenna. Good job. Take those CBCs. Check this white, check the whites. So this one, in terms of monitoring, isn't bad. Isn't bad. Draw some blood, take a look, and then go from there. Okay, I think that's everything on hematology that I wanted to talk about. So we talked about anemia, talked about growth factors. Now we're going to go to the GI medications. Okay. I have to use the bathroom, so just talk amongst yourselves. I'll be right back.
Hey, Becca.
Hey guys.
They should have given you extra for that.
No kidding.
So as a general announcement, Erica passed her T's. So Erica, take a bow. Well done. Well done. Very good. So if you look at your handout, there are groups of drugs. And because if I make this broad, it doesn't tend to show up, I'm just going to keep it like this. Let's start out with the medications for inflammatory diseases of the bowel. So there are two main inflammatory diseases of the bowel. So there's Crohn's disease and there's ulcerative colitis. Some 1 million Americans or so, that number comes from up to date, have some sort of IBD. There might be others who are not diagnosed. And both men and women are equally affected. My wife, in fact, has ulcerative colitis. Fortunately, her case is not very severe, relatively mild. So these two diseases, both of them have very definite genetic influences. Crohn's disease is not a classic autoimmune disease. It was thought to be. It's very clear from the research that's been done on it. It's not. Ulcerative colitis seems to be a classic autoimmune disease. The immune system reacts against the mucosal surfaces. Crohn's disease seems to be something altogether different. With Crohn's disease, it seems that the immune response is against the bacteria in your gut, and your GI tract is an innocent bystander. So that has changed the thinking on Crohn's disease. People looked at Crohn's disease in pretty grave detail. It really doesn't meet the requirements for a typical autoimmune disease. It's something different. So some people think there was this book that came out in 2016. And I don't remember the name of it, but it essentially popularized the so-called hygiene hypothesis for IBDs. Have you guys heard of that hypothesis? The hypothesis goes something like this, that humans are used to having a certain amount of parasite load, and their immune system is used to dealing with that. Because we've gotten rid of that parasite load, our immune systems now need something to chew on. So our immune systems take it out on our bowel or on our respiratory tract with asthma or something like that. And so what some enterprising people have tried to do is to sell you essentially little cultures of hookworms. And you can swallow them. You can get a relatively asymptomatic hookworm disease, but in some people, their IBD goes away. So this disease almost certainly has some efficacy, some explanatory value. I, for one, would not be a fan of giving myself hookworm, but there are medications essentially to kill the hookworms if they do get out of hand. But that is one of the theories essentially of what causes these diseases. What is clear is that if you have someone in your family who's closely related to you who has an IBD, your risk goes up for an IBD substantially. So there is a genetic component to it. Diets play an important role in the development of an IBD, but they don't seem to play a role as to whether or not you'll get one. They play a role as to when you'll develop it. Can they delay it? So on and so forth. Smoking plays a role in Crohn's disease. Namely, if you smoke, you're at increased risk for Crohn's disease. But with ulcerative colitis, smoking is actually protective against ulcerative colitis. And in fact, one of the treatments now for ulcerative colitis is a nicotine patch. When you look at the pathology of these two diseases, ulcerative colitis tends to affect, first of all, ulcerative colitis affects only the colon, and only the mucosa of the colon. It tends to be in the rectum, sigmoid colon, and descending colon, and it tends to be continuous. Crohn's disease, on the other hand, can be in any part of the GI tract. You can get sores on the mouth. You can have sores in the esophagus. It can affect your stomach, small intestine, or colon. Can start in the colon, can start in the small intestine. Crohn's is an equal opportunity offender. And Crohn's disease can affect all the layers of the mucosa. Can affect the submucosa, the muscularis, the adventitia, serosa, so on and so forth, blah, blah, blah. Crohn's disease too, if you look in the colon, you'll find patches of affected tissue. It's not continuous the way it is in ulcerative colitis. The tissue pathology too is unique. So in Crohn's disease, you get this kind of cobblestone look. That help at all? Okay, a little bit. See this kind of cobblestone look? That's really common in Crohn's disease. So you have this kind of thing that looks like bathroom tiles kind of look. Ulcerative colitis, you have these sort of pseudopolyps. Now, these pseudopolyps are inflammatory polyps like the type we talked about in genetics, but they're flat. They're easy to miss, and they can become cancerous because your colon is constantly being damaged, regenerates, damaged, regenerates, damaged, regenerates. You're at higher risk for colon cancer. So my wife has to have screenings every year. Way it goes. So when it comes to their initial presentation, they both have these features, symptomatic features in common. You get fever, abdominal pain, diarrhea. That diarrhea is very often bloody, rectal bleeding, and usually weight loss. In Crohn's disease, of course, the sores can be anywhere between the mouth and the anus. And because Crohn's disease can affect multiple layers, perforations and fistulas are actually kind of common. Do you know what a fistula is? No? A fistula is a hole that connects that tissue with another tissue. So for example, in women, you can have a hole that now connects the birth canal with the rectum. Sounds gross, but that's what happens. One of the most hopeful treatments, it turns out, for fistulas in people with Crohn's disease is stem cell treatments. Turns out adipose tissue-based stem cell treatments with particular artificial scaffoldings. You can make kind of an artificial bandage out of these scaffoldings, put the fat-based stem cells that you've treated with growth factors in there like that, and they'll heal up the fistula. That's in phase 3 trials. I'll bet you by the time you guys in your practice, this will become mainline.
Wouldn't that be dangerous to think, like, if they got a fistula between?
Yep. Yep.
So what would they do in that? Like, would they try?
You have to surgically treat it, and those fistulas get infected, major league infected.
Do they have to try and close it, or?
Yeah. Yeah. They're very painful too. Very painful. So with Crohn's disease, that's CD, that's not compact disc, that's Crohn's disease. Your patient medical history and physical exam are going to be probably the most important thing. Also, they need a colonoscopy. You have to have a trained gastroenterologist to look at the colon in order to make the proper diagnosis. There is a genetic test for Crohn's disease, but That test does not have the power to resolve Crohn's disease without a proper colonoscopy to diagnose it. Ulcerative colitis, kind of same song, second verse. It'll be restricted to the colon. Once again, you need a colonoscopy to properly diagnose it. A barium enema X-ray of the colon is also a good way to visualize it. So the initial treatment, usually the flare-ups are usually put down with oral steroids. That's meant as a short-term treatment because of the side effect profile of oral steroids, of course. So maintenance of remission, the aminosalicylates. What is going on? Ghost of Whiteman Gibbs. So these drugs, the advertised adverse effects are nausea, vomiting, headache, hypersensitivity. These drugs, frankly, are very well tolerated. The one that gets used the most, at least for ulcerative colitis, is mesalamine. That is available now in a generic. It was marketed as Asacol, but Asacol had a plasticizing compound in it that wasn't good for you. So that was withdrawn from the market. It was reissued as Delzacol, and then the patent ran out and now it's generic. It also comes as another oral prep called Pentasa. And then it comes in a enema form that's called Rowasa. And then there's also a suppository form called Canasa. Canasa. So Rowasa, Canasa, Pentasa, whatever. That's all mesalamine. That's the one that's definitely used the most. The other, sulfasalazine and valasalazine, olsalazine, those are mainly oral preps. They can be useful in Crohn's disease, but they don't work that well in most people, but they work pretty well in ulcerative colitis. All right, so your steroids are typically oral, but budesonide comes as a foam. The foam is inserted rectally, and it will essentially work its way all the way up to the border of the transverse and descending colon. So it can quell inflammation pretty nicely. These are meant to suppress flares. They're not meant to be maintenance treatments, but they do suppress flares pretty well. We talked about some of the side effects of those. The side effect list is long and pretty nasty. For Crohn's disease, the maintenance medications usually are these immunomodulators. So 6-mercaptopurine is a drug that gets used a good deal. And then azathioprine, cyclosporine, and methotrexate. That's usually low-dose methotrexate, not the high dose that's used for cancer. These drugs have some side effects, albeit at the dosages at which they're given, they tend to be pretty well tolerated. They can cause some GI issues. That tends to be transient. The other issue is that they can suppress the bone marrow. So patients need to have their blood drawn on a regular basis and checked, especially when they first go on it. And then after that, they should probably have a draw, probably every month. And then later on, maybe every 6 months, something like that. These drugs are mainly oral, but they do come in intravenous preparations. For maintenance, they're almost exclusively used orally. If those don't work, then you go to a biologic. These particular biologics get used for both Crohn's disease and ulcerative colitis. We talked about the biologics before. So these are the anti-tumor necrosis factor alpha medications. Remember, these come in injector pens. You inject them subcutaneously. Pretty well tolerated, but remember, the caveat, they're going to increase your risk of infections, in particular tuberculosis. So they have to be screened for tuberculosis before they go on these drugs. Usually the risk of upper respiratory infections goes up. Injection site reactions are pretty common. They're expensive, but if you fail with the oral drugs, insurance almost always pays for them. So there's infliximab, adalimumab, certolizumab, Remicade, Humira, Cimzia. For Crohn's disease, some people's Crohn's disease responds to antibiotics. We had a chap who worked in the admissions office. He did the transcripts for people. His name is Ron Holtman. Ron had Crohn's disease, and so did his daughters. Both his daughters have it. Ron's Crohn's disease responded extremely well to antibiotics. So if he had a flare-up, he'd usually get antibiotics, and his Crohn's disease usually calmed down. Again, that hyperactive immune response to gut bacteria, that's why it works. Now, antibiotics do not work for ulcerative colitis, but they do work for some people. Let me emphasize that, some people with Crohn's disease. So use metronidazole, ciprofloxacin. With metronidazole, you have a disulfiram reaction if you take it with alcohol. In other words, you puke your guts out. So don't take it with alcohol. Ciprofloxacin can cause joint lability and increase the risk of joint injuries, tendon ruptures, things like that. And resistance is always an issue as well. Nicotine, as we said, is used for ulcerative colitis, not Crohn's disease. So antibiotics works for some patients with Crohn's disease, not ulcerative colitis. Nicotine works for some patients with ulcerative colitis, not for people with Crohn's disease. Usually people use the transdermal patch. It usually irritates your skin, keeps you up at night, and usually causes irritability, nervousness. It's ineffective as a maintenance treatment, but it can take the edge off somebody's severe ulcerative colitis if they're using other medications and they're not working as well as you'd like. Antidiarrheals may help people with the constant diarrhea. The issue is that they can precipitate a condition called toxic megacolon. When somebody gets toxic megacolon, if you palpate their abdomen, you're going to feel this big, hard mass in their stomach. That's not good. Okay. So these are the types of drugs that you use for irritable bowel syndrome. dicyclamine is probably the main one that's used. It's very cheap. Cholestyramine we saw before when we looked at cholesterol. Because that tends to plug you up a bit, it can be used to treat diarrhea. So these should be used with caution. Also, dicyclamine and also hyoscamine, those are anticholinergics. So those will have anticholinergic side effects. So dry mouth, blurred vision, decreased sweating, so they may overheat more easily, some bladder retention, those sorts of things. This other stuff called Lomatil, diphenoxylate and atropine. Lomatil was very widely used, and then it was pulled from the market because it apparently caused heart arrhythmias and some people died on it. Then it was put back on the market about 3 years ago. And now it's being prescribed again. So you might not want to give that drug to someone with a bad ticker. Or if they have a bad ticker and they're going on that drug to dry them up, you might want to watch their heart rate really carefully. You might want to hook them up to an EKG. Can. They can, yeah. Yeah. Yeah, some doctors, some patients get a lot of relief from it. So some doctors really like it. Others say, oh, I won't touch that stuff. So it depends on the gastroenterologist. Yeah. Mhm. No. The demand for the drug was high, not just from patients, but also from gastroenterologists. And it turned out that people who had the heart attacks were people who had pre-existing heart conditions. We're going to see this with another drug that we're going to cover in the GI system too. That drug got pulled and then it got put back, but with very specific indications. So sometimes you take the data, you re-examine it, and you learn something new. Other times there's just such a demand for it that the FDA will kind of work around you. Now that did not happen for Vioxx. Rofecoxib. Rofecoxib, there were like 93 million prescriptions of Rofecoxib. And all those people, a small proportion of them had heart attacks. But that was a high enough number for the FDA to say, nope, pull it. So that particular drug is now gone the way of the dodo. Any questions about IBDs? One of the big things you need to watch for patients on IBDs is they have trouble gaining weight. They may be, especially with Crohn's disease, they may have malnutrition. And people with UC may be anemic. So if they are getting a few units of blood, can really be a good deal, especially if their hemoglobin drops below a certain point. So be checking essentially their blood, be checking essentially their weight. If they're losing weight seriously, then yeah. Okay, irritable bowel syndrome is a pretty common GI disorder that's encountered. You've experienced this one more commonly in women. What causes it is a great big huge black box. It is clear that stress makes it worse. There's 3 types of irritable bowel syndrome. There's an irritable bowel syndrome characterized by constipation, so it's called IBS-C. There's an irritable bowel syndrome characterized by diarrhea. It's called IBS D. And then there's one that's a little bit country, a little bit rock and roll. It's a little bit of both, and it's called IBS-M, mixed. So for the IBS-C, dietary modifications and then laxatives are going to be probably the mainstay treatment for those folks. For those with predominantly diarrheal types of disease, there are certain foods they will need to avoid. So foods with caffeine can also affect their bowel. Also, alcohol can make it a lot worse. So they need to really mediate their alcohol intake if they drink it at all. Also, this one, rule out lactose intolerance. That's very important because lactose intolerance can look like IBS-D. So for that matter, can celiac disease. Celiac disease, fortunately, is a very good blood test for celiac disease. So make sure you rule that out. For the mix, you're going to use antispasmodics. And in these patients, strangely enough, antidepressants are helpful in some cases. Help comes from the strangest places sometimes, doesn't it? Now, lubiprostone is a prostaglandin, and it increases the amount of chloride that goes into the GI tract. With that chloride, it's going to drag a lot of water with it. So it's going to take essentially the material in the colon and it's going to wet it. By wetting it, it'll expand it. That expansion is going to stimulate the movement of the bowel. And so it will soften the stool and increase the number of movements. So this will act kind of as a laxative. This drug can cause abdominal pain and nausea. It can also cause flatulence, gas, abdominal distension, and also headaches. This drug is approved for use in women. It's not been approved for use in men because its efficacy in men has not yet been established. This drug is also reserved for those who have failed other treatments. Linaclotide is also used for constipation like IBS. This drug activates a G protein coupled receptor that stimulates the secretion of bicarbonate and chloride into the bowel. So you get an increase in intestinal fluid and an increase in intestinal transit time. This causes a lot of the same side effects: diarrhea, abdominal pain, distension, flatulence, so on and so forth. Whereas lubiprostone is taken twice a day, this one's only taken once a day. And Jenna, this gets back to the question you asked. Allosetron, which was called Lotranex, this one was pulled from the market. And then the FDA convened a study group. They looked at it again. And they said it's only allowed in women with severe diarrhea. And it's also only allowed if they failed more conventional therapies. This is a serotonin receptor antagonist. And this is only to be used in women. So these two drugs, lubiprostone, olocitron, you just use them in women. Linaclotide you can use in men, but again, that drug is meant to be used if your other treatments, your laxatives and what have you, diet adjustment, if that's failed. Not been studied. Not been studied. And if I were a betting man, I'd say no. That's just based on the data I've seen, but I would not put a lot of money on that bet if I were a betting man, which I'm not. What about antidepressants? Antidepressants, some of them seem to improve the abdominal pain and other symptoms of IBS. In particular, IBS can affect your mood. So this includes SSRIs. These will slow the GI transit time. If it's a tricyclic antidepressant, that is. SSRIs will increase transit time. They have some analgesic properties, but it must be admitted that their evidence base is not great. They seem to work best if pain is the main symptom. And again, these drugs take a while to start working. They take about 4 weeks to start working. Antispasmodics, they're meant to deal with the bloating and the consequent abdominal pain of irritable bowel syndrome. This includes dicyclonine and hyoscamine. So these are smooth muscle relaxants. If you get really colicky pain, these are meant to relieve that. They're anticholinergics. You get dry mouth, tachycardia, urinary retention, dizziness, sedation, blurred vision, blah, 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 blah. Patients, if these are prescribed to patients, they're supposed to be used PRN. Do you know what PRN means? Latin is pro res nata. Pro res nata means for use only. You use them as needed. Pro res nata, only as needed. Don't be on them all the time. They're PRN. All right, it is break time. Let's go ahead and take 5. And then we'll resume and talk about drugs for, nausea. I'm sorry. This cough is keeping me up at night and I'm not sleeping well, so I'm just tired all the time. That's why my cough is getting better. I practice all night. No, because usually you're giving the response to the doctor. Because she doesn't medicine wrong.
Oh, they don't.
Right, she doesn't medicine wrong. In that case, if you gave it as directed, my understanding of the law, I'm not a lawyer, is that plus you don't have to do pockets of hospital. They're not gonna sue you.
Or if they're included in the suit, usually. Usually when you work for a hospital, you have insurance with the hospital. So if there's, medicine there or something like that, or if something happened, you must be sued, and hospital to settle. Let's say hospital deal. There's some suits that fight.
Did she really get 15 years?
That's what I.
Yeah.
That is crazy.
And apparently, right after she did it, she made a mistake.
Yeah, and she reported it.
And of course, she followed,
Every
did
protocol.
everything right. And it was a mistake, it was a horrible mistake. But
So 14 years, it's also how many lives did she save before that in this one, she just gets completely.
well, see, on this assumes she made a mistake.
Yeah.
And she didn't.
Like, no.
She made a mistake, an honest mistake. I don't know.
Oh, yeah.
Yes, you may quote.
Yeah.
Oh my gosh, did anyone's power just flash?
So you made one Dropbox for the ATI exams. Are you going to make a new Dropbox for every?
Yeah, I'm gonna have to. So,
Would you rather us just take all of them and then just drop the whole PDF in there? Because I think there's a way you can have a PDF that shows all the.
yeah, you can do that. That's more work. All right, let's get back on the boat and get on the river. So the vomiting response, as you can see here, is triggered by impulses to the so-called vomiting center. This is a nucleus in the medulla oblongata, so it's in the brainstem. Impulses are received from sensory receptors, such as the chemoreceptor trigger zone. The chemoreceptor trigger zone is dorsal to the vomiting center. This then receives material from the pharynx, from the GI tract, what have you. When excited, these afferent impulses are integrated into the vomiting center, resulting in efferent impulses to the salivation center, the respiratory center, the pharyngeal, GI, and abdominal muscles. Those are all coordinated, leading to vomiting. The goal is to rid your body of something that is bad for it. That's the goal of this response. Unfortunately, it can also continue even if there's nothing in your stomach, leading to this phenomenon known as dry heaving. Also, if you are trying to keep food down and the vomiting response won't even let you keep food down, patients can experience not only malnutrition, they can experience serious electrolyte and bicarbonate loss. There's several different causes of vomiting. It could be gastrointestinal, it could be cardiovascular. For example, a acute myocardial infarction can make someone sick to their stomach. Renal disease can cause vomiting. Migraine, headaches sometimes can cause people to lose their lunch or breakfast or dinner. Psychogenic causes, people may throw up in anticipation of something really awful, like one of my exams or something like that. Yes, it was a joke. Therapy-induced causes, cytotoxic chemotherapies can really do a number on your GI tract. Drug withdrawal, so opiate withdrawal, for example, can cause vomiting. And so can pregnancy or operative procedures or something like that. So you can see here the vomition center and then the chemoreceptor trigger zone that is dorsal to the vomiting center. All that input that's then outputted to the vomiting center. The vomiting center then sends it to all the places that need to be coordinated in order to have a good upchuck. So there are several groups of drugs that are very good anti-vomiting drugs, drugs that are used to treat nausea. Antihistamine, anticholinergic agents are very good for motion sickness. So this would include things like so-called Dramamine, diphenhydramine, and then diphenhydramine, Benadryl. That can be used as well. Hydroxine, that's used for anxiety, but it's also good for vomiting, motion sickness. Meclizine is available over the counter and is pretty effective for car-induced motion sickness. Not so good for boats where you're doing, this sort of thing. Meclizine, if you don't get that sick, is useful, but a lot of people who need something stronger, scopolamine is actually better for that. And look, there's scopolamine. So that comes as a transdermal patch. Old story. When you put the patch on, you usually put it on one side usually causes one pupil to dilate. And people with the patch on will get super duper freaked out. They'll think they have a brain tumor or something like that. And it's just a scopolamine patch. So how do you head this off in the pass? You warn them. You warn them. Warn them what to expect. That way, if it happens, they don't freak out. They don't go see the oncologist. I must have a brain tumor, something like that. You put on a scopolamine patch, dear. You're fine. The nurse practitioner over here at Holton Health Center, Mary Rick, she retired several years ago. Mary was as dear a lady as they come, but Mary said sometimes when it's yourself, you're not the most objective observer. So she and her husband, Steve, who's an attorney at the foundation up the road here, they went on a cruise and Mary gets terribly motion sick, seasick when they're on boats. She has to go scopolamine patch. Then she's getting ready for dinner and she noticed one eye was dilated over the other and she got really scared. So she's going through differentials in her head. Oh, what kind of tumor could it be? She's doing, this to make sure that her cranial nerves are fine. So I said, we need to go see the chip doctor. And so they went to the chip doctor, they had to call him. And then Steve started reading the literature essentially and talked about, well, if you have a scopolamine patch, one eye will be dilated. He said, Mare. And Mary was a nurse practitioner. In fact, the farm course I teach now for the HES students, Mary started that course with me. And she knew full well that was a side effect of that drug. But again, it's yourself. You're not objective when you're thinking about yourself. And Steve read that and she said, they looked at each other and said, let's go to dinner. So they went to dinner. Phenothiazines are really good for blocking nausea. One drug that gets used a lot in hospitals is promethazine, Phenergan. That's kind of a staple. Some of these others, they block dopamine receptors in the chemotherapy zone. They can cause excess sedation, particularly in the older people. They can also cause extrapyramidal reactions. You can get bone marrow issue and things like that, cardiac arrhythmias. Because of that, these are not used a ton. Promethazine is the weakest of these. That's why it gets used. The other ones, chlorpromazine, things like that, those they're used rarely. Droperidol is used for postoperative nausea and vomiting. That's what PONV means. And it's also used for chemotherapy-induced nausea and vomiting. So droperidol is a compound that comes from Mary Jane, marijuana. So when isolated and made in a pill form, it does a pretty good job as an antiemetic. You have to use it within the dose. If you go outside the dose, you can start to get arrhythmias. It's pretty sedational too, which if someone's just come out of surgery, they usually want to sleep anyway. So that might be a bonus. Steroids are good short term. Again, they're not to be used long term. They tend to be used for cancer-induced nausea and vomiting. The one that gets used the most is dexamethasone. That's a good drug for that. You have a patient with diabetes, you give them that, you really need to monitor their blood sugar because it'll play havoc with their blood sugar. It'll jump up. Reglan or metoclopramide, gets used quite a bit. It's very good for chemotherapy induced nausea. So this is given intravenously. This is a dopamine blocker, so you can get extrapyramidal effects. At the dosage at which it's given, it's usually fine. It can cause some drowsiness and dystonic reactions. If you see dystonic reactions where people start doing, chewing things like that, tics, that sort of thing, that could be tardive dyskinesia. Pull the drug ASAP. ASAP and call the provider. You'll see those usually around the face before you see them elsewhere. So if you start seeing for oral sorts of things, lip smacking, chewing, things with the tongue, things like that, big danger sign. Danger, Will Robinson, pull the drug. And if anyone has on their chart that they've had tardive dyskinesia, don't use this drug. They're at greater risk for tardive dyskinesia. And now we come to the jack of all nausea trades, the selective serotonin agonists. And Claire, I'm sure this is a drug you've seen before. Zofran. Oh yeah, this drug gets used a whole lot. You name the nausea, this will treat it. So ondansetron, trade name Zofran. In fact, in the EMR, it's probably still known as Zofran. Virtually everyone knows it as Zofran. And then there are derivatives of it. They notice they all end in citron because they are serotonin receptor antagonists. So there is dolasetron, granisetron, and polonositron. And ondansetron, even though it's the oldest drug, is the one really that's still used the most. Very effective drug. This drug will increase the QT interval. Usually not clinically significant, but if they're on something else that elongates the QT interval, you're at risk for torsade de pointes. So check that chart, check the meds are on. If you need to convince yourself, hook them up to an EKG. That's one of the downsides of this drug. Generally, it's well tolerated. These other things, fever, constipation, headaches, so on and so forth, those are not very common. On the average, drug is pretty effective. They also, that's the beauty of these drugs, they play well with other antiemetics. You can combine them. And if somebody says, really raging nausea, these drugs play really well with other antiemetics. Cannabinoids are effective for nausea and vomiting associated with chemotherapy. So there's dronabinol, which goes by the trade name Marinol. Marinol is especially effective in people who don't have an appetite. Cancer can completely shut down your appetite because you feel crummy and you just don't want to eat, you're losing weight, you don't have any energy. Marinol is a very good drug for increasing the appetite and also diminishing any sort of nausea they might have if they eat. Nabilone is a synthetic mimic of drugs that were discovered in cannabis. There is a risk for dependence. It's not high, but if the person, your patient, already has a tendency to be dependent on things, that risk is higher. It can cause mood changes and anxiety. Hallucinations have been reported, but all the data I've seen says that's not terribly common. Euphoria is a reported side effect, but that's not very common. So these things that you see there are pretty low frequency events. Usually it's pretty well tolerated. Tends to be reserved for people who failed other antiemetics, except certain oncologists I know, this is their go-to drug because it works in certain patients with certain types of cancers. So benzos, these two, lorazepam and diazepam, they essentially kind of put you to sleep. So the nausea and vomiting, if it's keeping you from sleeping, these will put you to sleep and you're fine. Benzos, of course, there's the risk of dependence. They cause anterior grade amnesia. If you want the patient to remember something, not good to use these drugs. Also, in elderly patients, they increase the risk of falls. Diazepam especially, diazepam is a muscle relaxant too. So they can lose muscle tone and that can be an issue. Now, with a younger person, it's usually not such a big deal. They're an older person and they're already at risk for falls. These are going to make their falls a lot worse. These particular drugs, the so-called neurokinin receptor antagonists, are drugs that antagonize a receptor for this small peptide called neurokinin. Neurokinin seems to be one of the peptides that's released by the effectors of the vomiting center. And these drugs block that receptor. They're given parenterally. They can cause kind of a needle and pins numbness at the extremities, asthenia. They can also cause hiccups. Not the worst side effect, but let's face it, it can be pretty annoying. If you have hiccups you can't get rid of.
I was so mad about his hiccups, and he was a diabetic, and he was like, I know what I use for my hiccup, I use ice cream. And they're like, your blood sugar is like 300, we can't give you a bunch of ice cream. And he was like shouting about it, he was like, I'm gonna sue you if you don't give me
Oh, for
ice
pity's
cream
sake.
for my hiccups."
I relate to that though. I get-
Sue you because you're not giving a diabetic ice cream. For pity's sake. You know, the kitchen probably has that diabetic ice cream that's got no calories in it.
Yeah.
You
we're
probably
gonna
give him some of that.
some, yeah.
Oh, here's the good stuff.
Yeah.
You know, the beauty of nursing is you work with people. The bummer of nursing is you work with people. These drugs are meant to be used acutely, not chronically, because they can cause liver damage. So this drug here, Prepotent, is a rep of this group. There are other members of this group, but Prepotent's the one that gets used the most. So this other drug, Tigan, is typically well tolerated, trimethylbenzamide. This is used alternatively if patients can't tolerate other agents. So it's a secondary agent just because other agents work better. Ondansetron, for example, tends to work better than this. This drug has anticholinergic effects and it tends to put you to sleep. That's the downside of it. Beyond that, it's fairly well tolerated. All right. Okay, now in the time we have left, there are 3 groups of drugs. I doubt we'll get to all of them. But let's just go ahead and talk a bit about drugs that are used for stomach acid. All right, so when it comes to stomach acid, if the lower esophageal sphincter is not closing all the way, you'll get backwash of acid into the esophagus. The esophagus is not made for acid the way the stomach is. The stomach has a high mitotic index. It has extensive blood supply to make sure that those cells have everything they need to divide fast, and they make a lot of mucus that protects them, and that mucus is laced with bicarbonate. All these protective mechanisms you don't have in the esophagus. So the acid, if it leaches up into the esophagus, it will ulcerate and erode the esophagus. The cell division of the esophagus will heal it, but that damage, healing, damage, healing, damage, healing predisposes you for esophageal cancer. And a precancerous condition is something called Barrett's esophagus. With Barrett's esophagus, the cells of the esophagus get converted from their columnar to a more squamous looking appearance. You can see this very easily on an EGD. This is called a metaplastic change. Metaplastic change. Esophageal cancer is very aggressive when it comes on. So the best way to deal with esophageal cancer is to just prevent it, because it is a ridiculously difficult cancer to treat. And it's aggressive, it spreads lots of places and not good for you. So one of the first groups of drugs that are used and they're available over the counter are the antacids. I am sure you've seen these in the store. Maybe even you used 1 or 2 of them. I won't take a survey at this time. So this would include things with calcium carbonate. That would be things like Tums. Calcium carbonate. Things with magnesium hydroxide. The hydroxide will neutralize the acid. That would be things like milk of magnesia. Milk of magnesia. That's magnesium hydroxide. Then you have also aluminum hydroxide. Aluminum hydroxide includes things like Maalox. And then various sundry other things. Sodium bicarbonate, that's of course Alka-Seltzer. These are good for acute relief. They're not good as chronic solutions to the problem. So the side effects tends to be either constipation, diarrhea. The real risk comes with acid-base disturbances, especially if you're using a lot of these. Aluminum and magnesium containing products can cause electrolyte disturbances. They can be very hard on your kidneys. And in fact, people with renal impairment should not use products that contain magnesium or aluminum. They can prevent the absorption of other drugs too. Some drugs depend on that stomach acid for absorption. Now they're very rapid acting, but they require frequent dosing. That's why they're good for acute but not chronic solutions to the problem. They will not heal gastric erosions. People will take them thinking if they take them consistently, they will heal the gastric erosions. No, that is not true. Then you have this stuff. Alginic acid comes in this product called Gaviscon. Alginic acid is a coating. It's a kind of sticky, slimy thingy. You swallow it, it's a powder. You have to take it with lots of water, but it'll coat any irritated areas of the esophagus or the stomach and relieve the pain. That's that results essentially. So it's a barrier to acid reflux, things like that. This can cause nausea, constipation, diarrhea, stuff like that. Once again, rapid acting, can prevent the absorption of other drugs, requires frequent dosing. Doesn't really neutralize acid, it just meant to protect tissues from acid. And it's not appropriate for the healing of established gastric or esophageal erosions. All right, then what is indicated for healing gastric or esophageal erosions? There are two drugs essentially in this group. There's the histamine receptor antagonists. Many of these are available over the counter as well. They include drugs like ranitidine, ranitidine. That is the one that goes by the trade name of Zantac. Zantac 75 and so on and so forth. You see commercials for it on ESPN and so on and so forth. Or this other stuff called Pepsid. That's famotidine. Notice that these medications tend to have Thai-dine after their name. Cimetidine. Also over the counter, this goes by the trade name of Tagamet. Then there's one that's actually prescription. There's nizatidine. Nizatidine goes by the trade name of Axid. That is prescription. The rest of these are over the counter. We are out of time, so I will talk about proton pump inhibitors on Monday. Do you guys have like 3 minutes to talk about ATI assessments? Is that okay? If you have to go, go, that's okay. I just want to talk. So we did kind of our first ATI assessment session. The software worked eventually. This semester is the first time I've done this course with ATI. The learning curve has been steep, and I don't want to penalize you guys because I'm learning a new software. I think that's unfair. So the assessments are more to get you guys used to. ATI won't grade you on the assessments, but I do want you to take. So there's 13 assessments. I want you to take at least 4 of them. And if you can do more than 4, that's great. To just get used to NCLEX type questions, but I won't grade you on them, okay? They're more for your own edification. Well, learning is a better word. Yeah. Yeah. Right, so those you'll save as a PDF, then you put them in a Dropbox that I'll make. Well, I made one, so that'll be the first one. So do those, and those you can take over and over and over again. And then PDF and put it in the Dropbox, then that's what I'll grade you on. And then I also have a Dropbox for your interview with the pharmacist. You guys all see that? And Bree, I voided your attempt so you can redo it since it didn't quite work the first time. If that happens, if you try to load it and it just goes kablooey, your computer shuts down or the internet, cosmic radiation or aliens land or something and it goes kablooey, just let me know and I'll void the attempt so you can retry it. I want you guys to get used to ATI. You'll use ATI a lot next year. Clara, can I get an amen?
I think so.
Yeah, they'll use it.
We didn't use it for fundamentals, but I think they will start using it more.
They will. They will. Mindy wants to get students onto ATI and using it as early as possible.
We didn't have that.
So again, I know there's been a few glitches here and there as I've been learning stuff and as they say ATI works like this and I try it and oh, no, it doesn't. And I get on with the chat people and I complain to them and they say, well, what browser are you using? You need to switch browser. I need to load a new browser and all that. Yeah, so it's, yeah. My woes are enough. But the thing is, you have to pass this class to matriculate into the program. I'm not going to punish you for that. This class, I think, is stressful enough and hard enough without you learning ATI and having to deal with ATI stuff. So I know some of you didn't do as well on the assessment as you wish you would have. Don't worry about it. Okay, don't worry about it. But do take some of them so you can get used to the questions, get used to the format, because that your NCLEX, when you take the NCLEX, it's going to be like that. A lot of those questions from the bank, they're old NCLEX questions. So do you have any questions about this when we kind of was first? Go ahead.
There was an intro to pharmacology section. Do you want us to turn in the quiz for that too, or just the systems that we've gone through?
I mean, the practice one?
Is there, like, there's all the different modules, and there's the first one is an intro to farm, and there's a test for that one too.
Yeah, do that one. Do that one. Yeah. Which you guys have been doing those anyway. So most of you have done those and shouldn't be an issue. So Mindy will be available to proctor tests. So I will, let's see, I'll go online 12:30. Does that work? Yeah. Because I started at 11 and nobody got on until after 12:30. So looks like 11 to 12:30 just doesn't really work for you all. So, which is fine, because then I can go to the gym, get my workout in, and then come back. Because I didn't get my workout on Tuesday and I was grumpy. So then I'll be on at 12:30 and I'll go till 3. Good. And then Mindy can do Mondays, 8 to 2 on Tuesday, Thursday, and Friday. So pick your time And Mindy will start next week. I'm starting this week. I want you to do at least 4 of those. No, she teaches Monday. She can do Tuesday, Thursday, and Friday, but in the morning. Yours truly is Tuesday, Thursday, and then Friday late. I suppose so. Okay. One of you had a question back there? Rebecca, was your hand up? I answered it. Okay. All right, good. Okay. Becca, get well. The rest of you, stay well. And I'll see you all next week at the latest. Okay, Becca, good night.